Hello, I'm Jim Reeves. Welcome to Patient Assessment Skills for Non-Emergency Transports. We're going to take a look at how healthcare providers, nurses, physicians, how they do patient assessments and document those. This is a screenshot of ESO, our EPCR product. As you can see with the stickman chart, this is where we would do a head-to-toe assessment on any injuries or any thing we take notice of on an extremity or body part with the patient that has a condition. Starting October 2015, healthcare is migrating away from the ICD-9s to the ICD-10 codes. This is important because we're going from 3,000 plus codes to about 10,000 codes. So in the old days when we would describe patients complaining of pain in the right arm, there would be an ICD-9 code for that. But now with the invention of ICD-10 codes, we have to describe in exact detail the exact location on the arm for that to be coded properly. So if we do it the old way and just say right arm pain, the Medicare or Medicaid may deny payment on the claim because we haven't described in detail the exact location. When we're doing neurological examinations, we need to look at the mental status of the patient. Historically, we're taught in EMT and paramedic school to look to see if a person is alert to verbal, painful, or unresponsive, or person, place, day, and event. So when we describe a patient as ANO times 4, we are implying that they are alert and oriented times 4 with no neurological or cognitive deficits. Many of us as EMS providers fail to realize that there are cognitive deficits present. So we need to take a deeper look. We need to look at their general appearance, their speech and language patterns. Do they have a deteriorated mood? What are their thoughts and perceptions? Is their information relevant to thought content? What is their insight and judgment? Again, we're looking for cognitive function, their attention and memory. We're looking for cognitive deficits. When you think about how law enforcement officers work when they're performing a DUI traffic stop, they have the suspect out of the vehicle in front of the patrol car, and they're asking them to do a set of cognitive function tests. May ask them to count from backwards from 10 or recite the alphabet backwards. All they're doing is testing the individual's cognitive function. Why is it that law enforcement officers can do this, but we as EMS providers fail to do that? So we need to start thinking like that and performing these cognitive function tests. You can ask a patient to remember a number and then ask them throughout the transport if they can recall that number. We need to ask them other questions besides just person, place, day, and event, because a lot of these patients, especially the ones that have confusion or dementia set in, will still remember who they are, where they're at, what day it is, and what event. We all know who the president is. So these are not very good questions when we're assessing cognitive function or looking for cognitive deficits. Many patients with dementia and confusion no longer recognize what is appropriate behavior. We need to be looking at these patients to see if there's presence for agitation, aggressive or abusive behavior, if they're using curse words or obscenities that are inappropriate or at the wrong time, unusual public sexual behavior, making strange noises, deterioration in mood, or rapid mood swings. All of these are indicators that dementia has set in. Many times, though, when we document a patient as ANO times 4, we're failing to capture the fact that the patient may have some dementia or confusion present. Let's talk about Glasgow Coma scales. Many of us use the Glasgow Coma scale on a routine basis every day. As a matter of fact, it's required in our EPCR reporting. However, a lot of us are confused as what the purpose of the Glasgow Coma scale is for. The GCS was created in Maryland at the R. Adams Cowley Shock Trauma Center as a way to assess for neurological deficits. So many times we see patients we transport every day documented as a GCS of 15. However, many of these GCSs are incorrect. The Glasgow Coma scale assesses 3 types of functions: eye-opening, motor response, and verbal response. So many patients we encounter on a daily basis will have eyes open spontaneously, so we would assess them at a score of 4. A patient who is verbally responsive, is oriented to person, place, and time, would get a 5. Or if there's a slight hint of confusion, we might assess them as a 4. Where we fail most often is on the motor response. Many paramedics and EMTs only look for one extremity. Give you an example. If we have a patient who is paralyzed on one side of the body, but they have a the other side of the body is functioning properly and they can follow commands. Many EMTs and paramedics would go ahead and give a score of 6. But the Glasgow Coma Scale was created to assess all extremities. Remember, this is a tool to assess neurological deficits. So if we have one side of the body that cannot follow command, then we would assess the lowest score possible. We have to assess all extremities. Let's take a look at 2 examples of how the GCS is applied. Let's say we have an 18-year-old female who is involved in a motor vehicle accident, rollover with ejection. You arrive on scene and you find the patient lying on the ground. The patient is alert and oriented ×4, has eye response, eyes are opening spontaneously, but you notice during your motor response assessment that the patient is paralyzed on one side of the body. You would assess that patient on the motor response as a 1, so therefore the GCS would be a 10. Let's take the same scenario, but with an 80-year-old patient residing in a nursing home. You arrive to pick up a patient to transport them to a dialysis appointment. You note that the patient has spontaneous eye movement and is alert and oriented ×4. But during the motor response assessment, you notice that the patient has paralysis on one side of the body. Would you assess them as a full GCS of 15, or would you assess them as a 10? Remember, the GCS, we're looking for neurological deficits. So the appropriate GCS score would be a 10 because we're looking for the lowest score assessing all 4 extremities. There are positive neurological deficits present, and so we would assess that patient as a 10. Recently, the Joint Commission has determined pain as the 5th vital sign. All patients must be asked and assessed for pain and discomfort. We need to be describing the pain. It may be physical discomfort that has characteristics of aching, pulling, tightness, burning, or pricking. You might explain that the pain may be mild or moderate or severe. Remember, pain is a subjective response to both physical and psychological stressors, physical or emotional situations. The pain may be acute versus chronic. Every patient, and I say that again, every patient must receive a pain assessment, and that must be documented in your PCR. We may not always be able to treat the pain. However, we still need to be asking every time we perform a set of vital signs if the patient is experiencing any pain or discomfort. Okay, let's talk about head-to-toe assessments. We're all familiar with the trauma assessment. We learned in EMT school and ITLS and PHTLS, the DCAP, BLS, and TIC. That's great to use on primary and secondary surveys on trauma patients. But on medical patients, we also need to be performing the head-to-toe. We're going to look at the HEAT, the head, eyes, ears, nose, and throat. We're going to be assessing the head for skin color. We want to look at their skin moisture. Are they dry? Are they diaphoretic? We're going to look at the eyes and the pupils. Are they equal, round, and reactive to light? Are they symmetrical? We're also going to look at the patient's neck. Do they have any presence of JVD or jugular venous distension? A lot of times medical patients, chronic medical patients, will have the presence of JVD. We also need to be looking at the chest. We want to describe the chest wall. We want to describe its shape. We want to describe the rise and fall. Is it equal? When we're auscultating breath sounds, we need to be assessing, are they normal or abnormal? We're going to listen to breath sounds over the tracheal region or the bronchial region, which is above the thorax, the bronchiovesicular region, which is between the second and first intercostal space, the vesicular region, which is the lung fields. Remember, we're listening for abnormal or adventitious lung sounds. We need to know what those sound like. We need to be able to describe wheezing, crackles, rales, rhonchi, stridor, or pleural friction rubs. It's very important that we know what these sound like. Even though we may take a patient on a routine basis, sometimes twice a day, we still need to be assessing their lung sounds and documenting that appropriately. When we're assessing the abdomen on non-emergency patients, we need to be looking for rigidity, pulsating masses, distension, pain, or listening to bowel sounds when appropriate. Most often we do not assess the pelvis on non-emergency patients. However, on trauma patients, we do need to do a pelvic assessment. We don't do the pelvic rock anymore, but we do apply pressure to assess if there's any pain or rebound tenderness. Most commonly, we do not get a chance to look at the back of the patient. However, when you do get that opportunity, it's a good idea to go ahead and take a look to see if there are any decubitus ulcers or pressure sores. We do need to listen to lung sounds and the lung bases on the back of the patient when possible. Let's talk about extremities for a moment. This is an area where we fail to capture, a lot of times, a good assessment on patients. When we're looking at a patient's extremities, we really need to be taking a strong look at their muscle tone. Many patients who are elderly and are not active begin to lose muscle tone rather quickly. We call this muscle disuse atrophy. It's present in quite a few patients. I'll tell you a quick example. I transported a patient recently that is a well-known celebrity. The patient had, previous to the injury, was a very healthy, active person. I was able to meet this patient 6 weeks after the injury occurred. And what was amazing to me was to note that the patient's muscle tone had decreased to the point that the only comparison I could make, that the patient looked like an image from a concentration camp or an Auschwitz survivor. The muscle tone had decreased so drastically that if we were to measure their arms prior and post-injury at the time of transport, we probably lost several inches. So it does not take long. Muscle disuse atrophy starts setting in within a week to 2 weeks. So we really need to be looking at the muscle tone. We also need to be looking at range of motion. Does the patient have a limited range of motion? And most common, we fail to document that as well. When we're doing range of motion exams, we don't expect you to lay the patient on the floor and do a full degree scale range for test for range of motion. However, we do need to ask the patient to move their extremities, as just demonstrated here on the slide. We can ask the patient to bend the knee and raise towards the chest. We can ask the patient to rotate and the adduction of the hips. So can they go in and out? We also need to ask them to invert or evert their ankles and feet. We can inspect their feet and look for range of motion as well on our own. Many times you'll be able to capture that information just by watching the patient, especially on their upper extremities. We can ask the patient to flex and extend passively and actively. We can ask them to pronate the forearms while the elbows are flexed, or make fists with extended fingers. Flex or extend the wrist, and move hands laterally and medially. So when we meet a patient and we want to do an upper extremity range of motion test, we can ask the patient to lift their arms out in front of them, lift the arms to the side, raise the arms above their head. Those are really good indicators of range of motion, so we need to be asking the patient and documenting that appropriately. Here's an example of a chart provided to us by Medicare. We attended a conference recently that some folks from Medicare said that in the very near future, all non-emergency transports will be required to document range of motion. As you can see from the center of this graph, there is a patient laid out on a table. We don't expect that to be possible in our industry. We're not physical therapists. However, we need to do the best we can to describe the limits of range of motion. If we can put degrees of limitations, that would be great. But this needs to occur on every non-emergency patient you transport. Essentially, everyone that is not going to an emergency room, we need to be looking for decreased muscle tone and decreased range of motion. We also need to look at contractures. Many times we encounter patients that have contractures, but a lot of us fail to realize what causes contractures. Contractures are neurological deficits. And when neurological deficits are present, that needs to be documented and very well described in your patient care report. Contractures can be described as adducted internally rotated shoulders, flexed wrist, pronated forearm, clenched fist, flexed elbow, and thumb and palm deformity. As you can see on the chart here, you need to know what each one of these type of contractures looks like and how to describe it in your narrative. Many charts we review do not describe the contractures. Many charts do not even describe that contractures are present. This is a medical condition that would generate a condition code. Let's take a look at pressure sores and how to do pressure sore assessments. Many times when you encounter a patient in the field, they're going to have positive pressure sores. However, you will not be able to determine that because the wounds are bandaged and covered. That's where we need to be very good investigators and ask the appropriate questions. We need to ask the patient, we need to ask the staff, and we need to roll the patient over and take a look at their back. Pressure sores are defined as localized injury to the skin or underlying tissue, usually over a bony prominence that is the result of pressure or pressure combined with the shear of friction. They could be stages 1 through 4, and they could be located on the lateral side, heels, sacrum, buttocks, head, arms, elbows, and back. As you can see from this graph here, this is a patient lying on the patient's back, and you can see from the red indicators where pressure sores may develop. Now, many of you watching this video are sitting in a chair. If you were to sit in that chair for an extended period of time, your buttocks would begin to hurt. The reason that occurs is because you're applying pressure to tissue. Imagine yourself as a patient lying in bed most of the time or sitting in a wheelchair most of the time. When you're not up and moving, you're applying pressure to that tissue. And as time goes on, pressure sores begin to develop. This graph shows what a stage 1 looks like. Stage 1 looks like a small scab. A stage 2 looks like a blister or a burn. A stage 3 begins to get into the upper layers of the skin tissue. And stage 4 is in the lower layers of the skin tissue or begins to get into the muscle tissue. Remember, many of the times that patients have pressure sores present, they're going to be covered. They're going to be bandaged up, and you will not be able to visualize them yourself. We don't expect you to remove the bandages to do a wound assessment. You need to do your best when asking these questions, asking the patient to determine. If a pressure sore is bandaged up, most of the time it's an advanced stage, especially if the bandage is seeping or there is fluid evacuating from the site itself, and the bandages have to be changed regularly. So we're going to have to ask those questions and do the best we can to document if the patient has a stage 3 or 4 bed sore. We need to describe the exact location that all the pressure wounds or bed sores are present. When we're documenting patient history, a detailed assessment of the patient's medical history must be performed. This shall include all subjective information obtained from the patient. In addition, we need to get objective information from the medical staff, the patient's chart, the physician diagnosis report, and the MDS sheet when possible. Previous medical history is a good indicator of medical necessity for non-emergency transport. So when we're looking at previous medical history, we're looking at their diagnosis. Those codes that they are assigned when their diagnosis codes from the facility also translate over to the ambulance side. So that's why history is very important. We also need to be asking medications. More importantly, we need to know what medications they're presently taking, what medications they're supposed to be taking that they're not, what medications they're taking that are not theirs or maybe over the counter, and we need to know that they're compliant with the appropriate dosage. We do a good job in EMS at asking what medications they're on. However, we fail commonly to determine if they're taking their medications appropriately. Okay, now that we've talked about patient assessment, let's take a look at a couple common situations that occur in EMS. You may get a call at 3 o'clock in the morning to a nursing home for a patient that has critical labs. And the patient may be sitting upright, alert and oriented, and in no distress or discomfort. And you're asking yourself, why am I taking this patient to the hospital? This happens very frequently for Medical and Medical Response. And most commonly when these charts are documented, we do not get paid for those. But what we really need to take a look at is why they're going to the hospital and what's really going on with the patient. Critical labs are defined by the Joint Commission as any result or finding that may be considered life-threatening or that could result in severe morbidity and require urgent and emergent clinical attention. So even though you may find the patient in no distress, critical labs still are an emergency and require a visit to an emergency room. Abnormal labs are defined by the Joint Commission as a non-emergent, non-life-threatening result that needs attention and follow-up action as soon as possible. The most common critical labs that we encounter in EMS are hematocrit, potassium, hemoglobin, troponin, platelet count, white blood cell count, glucose, and calcium. This is an example of an actual lab report on an actual transport that was performed in our Mississippi operation. If you'll notice, the hematocrit is 19.7. It does indicate CL right next to it, and the normal range for hematocrit for this patient is 37 to 47. The hemoglobin is 6.7, again indicated as CL. The normal range should be 12 to 16. This patient is experiencing a medical emergency. However, the patient could present alert and oriented and in no distress. We are concerned as healthcare providers that this patient has potentially an internal bleed. This would be a life-threatening emergency and require transport to an emergency room. even though the labs may have been drawn 13 hours prior. By the time it's noted, they're assessed and reported back to the facility and the physician notified, it may be an extended period of time. That does not mean at 3 a.m. we still do not have to intervene and transport that patient to the hospital. Oftentimes, when we're transporting patients that have critical labs, we fail to document what the lab is, what the range was, what the normal range was, and what the results mean. That's why we're not getting reimbursement for many of these transports. So, we have created this chart. This is called a lab value chart. You will find this in the ambulance, and each one of you will be provided this chart. If you notice in the column to the left, which states the name of the test, the column to their right of the name is the purpose. The middle column states the normal ranges, and the two right columns are the high results and low results mean. So we need to be documenting when we find these critical lab patients what the name of the test was, what the normal range is, what the patient's range is, and what the high results or low results mean. Let me give you an example. In the early 90s, paramedics were trained to document rule out when they were transporting a patient. For instance, we would transport a patient with chest pain, rule out AMI, or acute myocardial infarction. That changed in the late 90s as it was determined that that was our way of diagnosing and we shouldn't be diagnosing. So they took that out of paramedic standard practice. We're bringing that back for these critical labs. We're asking you to take a look at this chart when you transport patients with critical labs and document what the high results can mean. So for example, we could say when the patient on the previous slide that has a low hematocrit, low hemoglobin, we would transport documenting that the patient has a low hematocrit hemoglobin, document their range, and state that the patient is being transported to rule out the potential for internal bleed. That information right there gives the coders good information to code that chart appropriately, therefore we would get paid. But when we fail to capture that information and we state that we're just transporting a patient with critical labs, the coders are not able to capture any information and we just document it with minimal codes, and most often it results in no reimbursement. Let's talk about feeding tubes for a moment. We transport feeding tubes quite commonly in patients who have feeding tubes. We need to understand the different types of feeding tubes. As you can see in the slide, a patient could have an NG tube, a PEG tube, a J tube, or a G tube. When we get called out for these patients at a skilled nursing facility that has a G tube or PEG tube pulled, it needs to be reinserted. If you look at the picture on the right, you can see that it is a surgical incision from the exterior of the body into the stomach of the patient. So when this tube is pulled, we now have an ostomy, or an opening, from the exterior of the body to the stomach. That's why this is considered a medical emergency, and it must be replaced by a licensed physician. Commonly, an X-ray would need to be performed to determine that the placement was confirmed placement. So that's why this is a medical emergency. We also need to be cognizant of the fact that with an ostomy, we could develop infection. The patient could become septic. That's why these go to the hospital by ambulance. We should also be familiar with tubes, trachs, and ostomies. Very common, we transport trach patients, even patients who can walk that have a trach. The reason that trach patients go by stretcher is because we have to be able to perform airway management. Trach patients are notorious for developing mucus plugs that they potentially could not clear. That's why we take them with EMT or paramedic in the back so we could clear their airway if necessary. Colostomy patients that is not a condition that requires ambulance transport. However, you still need to be aware of colostomy patients and what those entail. Chest tubes, that is a paramedic skill, and we need to understand and document appropriately how to transport chest tubes and what we've had to do with those chest tubes en route. So when documenting patient assessments, we need to be documenting the complete head to toe. We're looking for the pertinent findings, the pertinent negatives, we're looking for neurological deficits, we're looking for limited range of motion, decreased muscle tone, and the Glasgow Coma Scale. Here's a sample non-emergency assessment that you could document in your narrative. Patient presents conscious and confused with a GCS of 13. Cognitive deficits are present and the patient is agitated and aggressive. Heat is clear, pink, warm, and dry. Pupils equal and reactive to light. No tracheal deviation, no JVD. Chest is clear, symmetrical rise and fall. Lung sounds were clear with upper bibasilar rales. Patient has stage 3 decubitus ulcers to the lower back, buttocks, and heels. And the abdomen was soft, non-tender, with no distension or rigidity. Pelvis was stable. Upper extremities were weak with limited range of motion due to muscle disuse atrophy. The patient is unable to flex or extend extremities without assistance, and the patient has bilateral above-the-knee amputations. This represents a sample of an assessment narrative, and it's not the complete narrative, but this is a good tool for you to use when documenting your assessments of non-emergency patients. Let's take a look at a couple of patients and do a practice assessment. This patient here, I do notice several things that are red flags. Number one, the patient is inappropriately restrained. We would never want to restrain a patient like this. But let's take a look at their potential medical conditions. If you look to the right of your screen, you'll notice the patient's arm is very, very skinny. That would be a good indicator of muscle disuse atrophy, decreased muscle tone. As this patient is aged and does not use his upper extremities in everyday life, his muscle tone has really started to decrease and muscle disuse atrophy is set in. You'll notice the patient is hunched forward. We don't know why that is, but that could be kyphosis. We also notice, if you look at the patient's right hand, that the fingers are protracted inward. That could be a contracture or a neurological deficit. At first glance at this patient, and we're not going to be able to get a whole lot of information just by looking at this patient, we can tell that she does have good muscle tone, but she is leaning to the right. So my first question would be, is she asleep? Has she had a stroke? We don't know those questions. We don't know what her range of motion is. But when we're doing our first impression, I can tell that she's leaning to the right, she is hunched forward, and there potentially is a medical problem going on with the patient. If we look at example number 3, we notice a gentleman sitting in a wheelchair. He does have a restraining table. He is hunched forward, and he also has some medical shoes on. That would indicate to me that this patient probably has some psychological problems or some neurological deficits because he's got the restraining table. We notice that he is leaned forward, so he may not be able to maintain upright stability, maintain truncal control. He may have a lack of coordination or unsteady gait, unsteady balance. That would be a good indicator of why he's in the wheelchair. But looking at the medical shoes, he also could potentially have pressure sores on his heels. Now let's watch a video of a patient that is experiencing some dementia and confusion, and let's see how you would note this patient in your record. As we just watched in the video, you noted a patient who had extremely aggressive behavior. He was confused at his location. He was having thoughts that weren't congruent with reality. And so this would be an extreme example of a patient with dementia or confusion. Most common though, most of the elderly patients we transport will not have this degree of confusion. You might encounter this type of patient in a lockdown unit at a skilled nursing facility. However, most of the patients that you meet will not be in a lockdown skilled facility, but will still have some degree of confusion. We need to be looking very closely for that. It's important to remember why you're completing a PCR report on every patient contact. Yes, we are trying to capture the medical information for medical legal purposes, but the PCR also is how we bill for transport. The information that you document determines how the PCR is billed. Most healthcare organizations have coders that go through and data mine your narrative. What they're looking for are conditions that they can assign codes to. So when you document a thorough narrative and a thorough assessment, we will be able to assign as many codes as possible to that ticket. That's why it's important for you to capture this information. So I hope you've learned something today. That concludes our discussion on patient assessments for non-emergency patient transport. Thank you very much. I'm Jim Reeves.